Charter Local Edition. I'm Brad Pomerance inside the state capital of North Carolina. We're in Raleigh. We are joined by Senator Ralph Hise, and he is a member of the North Carolina State Senate Chair of Health and Human Services, as well as a few other committees, but let's focus on health if we may. One could say congratulations is in order. We have significant Medicaid reform in this state, a huge part of the budget, 17% of the budget, and we now have a reform package that's passed. Give us a sense of the package.
First of all, thank you very much for the opportunity that's coming through. Medicaid reform is something that we really worked a long time on this state. Coming into the legislature, we've dealt with a Medicaid system that its budget can be off $400 to $500 million in a year. So coming in, it's growing faster than even revenues are coming into the state in that one portion. So as we've dealt with that for 4 or 5 years now, and so coming in, it just became very important to us to focus on coming up to a system where we could begin to control cost.
And as I understand it, currently the office owes medical providers nearly 2 years of back payments for the poor. Is that still percolating in the background?
It can be, and that's kind of become more their normal processing time for some of these payments and others that's come through. And a lot of the healthcare providers out there have struggled with the system that's coming in, and it's a challenge for even after you reform it, because even after you change the payment structure, you're going to have a backlog of payments coming in under the old system.
But this reform is revolutionary. This is not tinkering at the margins. This is a serious effort.
It is. At its core, it fundamentally changes how we pay for health care under Medicaid. It changes us from a system where we pay a fee for service. So for every x-ray you perform, for every hospital visit, for every doctor visit, we were paying set fees and then cost settling those fees coming back. We now turn to the provider communities, both in insurance and providers and hospitals and doctors, and say, to form groups now, we will now pay you a per member per month rate to allow you to manage all the health care needs of the individuals under the entitlement program.
And that seems to be the direction even of the Affordable Care Act. I mean, that whole notion that we want to incentivize healthy people, and so to provide per service, that's a disincentive. We want people to get sick because then the doctors can make their fees. And so how has the system, I mean, the system hasn't even gone into play yet, but explain how it will work. There will be the insurance groups. I guess there will be 3 contracts that are statewide, and then there's the PLEs, known as the provider groups, that will have 6 or 7 contracts in certain areas. Will they compete against each other?
Yes. What you'll have, first of all, is you have statewide contracts that we have 3. And either provider-led group or insurance companies can bid to provide services statewide. So you have to have a network of service providers that would cover the entire state that have signed up with.
So even a PLE could do that?
Yes, even the PLEs can do the statewide that's coming in. And then we'll divide the state into 6 regions. And only provider-led entities can provide services in just a region. That's coming in. So as a Medicaid recipient, you will then have a choice of at least 4, but there will be more, can be more than 1 PLE in a region.
So it's 3 plus 1.
But there could be 2 or 3 in that particular region. So you have a choice of at least 4 entities that you will choose to provide your services.
So you can pick one?
Yes.
How will one decide?
A lot of it will be about, a lot of people I think will choose based on the hospitals they work with and whether they're running those, the insurance companies they're familiar with and providing products in other areas.
I'm wondering, can the PLEs truly compete with the insurers? I mean, the insurers have such economies of scale going, especially because they're not just North Carolina, they're throughout the nation. So how will they compete?
Well, I think the first thing you have to look at is that providers really have 2 benefits in this contract system that's coming up. Number one, to manage patients and have that population, but they still remain service providers for the other contractors and may be part of their networks as well. So they still have the ability to negotiate those contracts with the insurance companies or the statewide entities, as the case may be. For example, your hospital, I can't provide that any regional hospital could create a statewide network that doesn't have every major hospital involved in it. So they will have separate contracts that will choose how they get paid from all 4 entities. And then they will have a separate entity set up that will manage the care of individuals.
It seems almost like inside dealing. I mean, you know what you're going to charge, and then you're going to ask what?
Technically, under antitrust laws, they can't. They will have to be a separate enough organization that
I
they
hear
don't
you.
have to
Okay.
do those. But those are under federal antitrust
I
laws
understand.
that exist that are coming in. But they will have revenue streams from both that was coming in. But literally, is the experience in managing patient health? It's where providers have a huge advantage.
So who now will carry the risk?
The providers in themselves will carry the risk. Now, we've required them to have insurance and reinsurance
Right.
requirements to be able to make sure the state is not on the hook for those risks and others. So if costs exceed the expectation, but the per member per month we're paying them isn't just a function of 10,000 individuals and here's the per member per month. It's risk adjusted too to individuals with certain conditions will receive higher per month payments. Children and infants will be a very different per member per month than you would see the disabled and the elderly coming in those processes. So those will be categorized based on the population that sign up for a particular plan as well.
So given that we are moving the risk away from the state, could it be that this takes us closer to the state of North Carolina accepting the federal Medicaid expansion? Because the big concern there, as I understand it, is while the federal government was covering 100% of the expansion costs, it drops in later years. We're already in that later year. But now if it's being shifted to these private entities or PLEs, the state doesn't have as much risk. Is that accurate?
Well, what you have here is that for every dollar we spend in Medicaid right now, we get a approximately $2 federal spend.
Okay.
So all of Medicaid right now is $1 state, $2
Right.
federal for their populations. What they've added in now is this new expansion offering that they've placed in the state where their match is higher. They cover, for the first 2 years, they cover 100%,
right.
and that drops to 90, and then they don't, the legislation
We don't
actually
know
doesn't
yet,
say
yeah.
anything what happens after 2020 with the match rates. I fail to believe that the federal government is going to take this expansion population, which is the healthiest of the population in the group. It's individuals who aren't disabled and others that are working age populations that are up to 138% of federal poverty. And pay 90% of the cost for that population, but for the disabled, for pregnant women and others, they're only going to pay 65%.
But the challenge becomes, I mean, you look at states that have accepted the expansion, Democrat and Republican states, their insurance, uninsured rates are just dropping like flies, whereas the states that didn't accept the expansion, like North Carolina, still very high uninsured rates. And ultimately, who winds up paying that but the state? Because if you don't have insurance, where do you go? The emergency room. And who pays the emergency room bills if you don't have insurance? The state.
Well, actually, we've seen under the covered population that utilization of emergency rooms actually goes up when they're covered under Medicaid that's coming in the first years. They don't necessarily change those habits
right.
that are coming in. And actually, Medicaid itself has a maximum $3.90 copay, and you pay the copay if you go to the emergency room. You pay the copay if you go to your doctor's office.
Education's critical.
That's what coming in. So I talk to doctors all the time who have offices near hospitals, and they'll have Medicaid patients come in, and if the wait's too long, why don't I just go to the emergency room? That's what coming in.
But what do we do about that uninsured population?
Well, I think the first concept is what should we be covering as a state? Medicaid right now already covers 1 out of every 5 individuals' health insurance in the state. We're doing almost 60% of births now are paid for by Medicaid. That's what coming in. What are we responsible for coverage and others? And we have large coverage for disabled populations, for pregnant women, for children that are coming in. The question is, do we extend that to what are considered now able-bodied adults that aren't senior citizens and others that are coming into this process and cover them just on the basis of their income?
And we will talk about that the next time you're on the program. Is that fair? It's a complicated conversation, but I thank you for joining us,
Thank
Senator.
you very much. I
My name is
appreciate it.
Brad Pomerance. We're in Raleigh, North Carolina, and you're watching Charter Local Edition.
Thank
We could have gone on and on and on.
I understand.
But it is tricky. I mean, it's a tricky